Welcome to the Bronchiectasis and NTM Association podcast, where we're here to share valuable insight from leading health experts, heartwarming stories from people living with bronchiectasis and NTM lung disease, and the latest in health research and treatment. Please subscribe, follow us on social media, and visit bronchandntm.org to learn more. Just a quick note before we get started. This podcast series is intended for educational purposes only and is not suitable for medical advice. Please consult your medical provider if you have any questions. Having bronchiectasis, unfortunately, also means facing exacerbations. Today, we are joined by Dr. Solomon, who will explain what exacerbations are, what can trigger them, and how they can be better recognized, treated, and even prevented. He will also highlight new research on how the microbiome contributes to exacerbation and share practical tips for keeping it as healthy as possible. So welcome, Dr. Solomon. Thank you so much for joining us today. To start, could you just tell us a little bit about yourself and where you're joining us from?
Sure. Hi, Alyssa. I'm Marty Solomon. I'm a faculty at the University of Alabama at Birmingham. I'm an associate professor of medicine there, and I am the director of our bronchiectasis and NTM clinical program and one of our research directors.
So to start our conversation about bronchiectasis and NTM lung disease, I'd like to start with the basics, just so our listeners can all be on the same page. Can you briefly describe to me what an exacerbation is?
Sure. So bronchiectasis, as many will be aware, is a condition associated with oftentimes lots of cough, sputum production, shortness of breath, other daily symptoms. An exacerbation is essentially a change in those symptoms that can become concerning to someone with increasing amounts of cough, sputum production, shortness of breath, fatigue, sometimes other symptoms like fever, sometimes lower oxygen saturations, decline of lung function, and can be associated with severe infections. And so the clinical entity or clinical definition of an exacerbation is a change for several days in one or more of those symptoms in sort of a cluster, and oftentimes is associated with having a new infection. It may be a viral infection. It may be a worsening of a chronic infection that the patient may already have. It can be an exposure can do that, but it's a cluster of those and constellation of those symptoms happening and worsening over several days.
I seen that it was 3 or more symptoms within a 48 hours period. Would you say that's still pretty much the guidelines?
Yes, there is a research definition of exacerbation, which fits what you just said, the kind of multiple symptoms, 3 or more for 48 hours. And the reason we have that research definition is that many of the drugs that are being moved forward in the clinical pipeline for bronchiectasis target patients that have frequent exacerbations, which is a concerning phenotype of the disease state because it can be people that can progress. And so to establish what an exacerbation is for a research study, that definition has been put forward and used for many of these trials. So we have a standardized definition of it. Different clinicians may use a slightly different definition in their clinical practice or with you when thinking about your symptoms. But suffice to say that in general, an exacerbation is a prolonged worsening of symptoms of the disease state. And then, as you alluded to, that research definition helps us to standardize that to be able to target exacerbations for clinical trials.
Okay, so any deviation in your typical symptoms might indicate that you're starting to enter into an exacerbation.
Correct, and that's right. And many of us as clinicians in the space will tell patients that's what we need to hear from you when you're starting to have worsening symptoms. If those are more than just a short-term deviation from your normal, that's probably signaling an exacerbation. That's a time for us to think about intervening or at least hear from you and check you out so that you can be examined and or have some intervention to try to deal with that exacerbation before it becomes worse and you get much sicker.
So you mentioned some of the common triggers, a lot of them being infection. So bacterial infection, viral infection, would those be treated the same, especially with that like viral infection? Would you typically treat that with antibiotics?
Yeah, it depends on the patient characteristics. So oftentimes patients will get antibiotics for a few reasons. One is patients that have bronchiectasis, which falls under the structural lung disease category, are more prone to getting secondary infections, secondary bacterial infections, even after an initial viral insult. And so they may have a viral illness, and then either that virus triggers a worsening of a chronic bacterial infection. A common one of those would be pseudomonal infection or methicillin-resistant staphylococcus infection like MRSA. So those may trigger a worsening of that infection, or it can trigger the propensity for developing another secondary infection that's new after the virus. So oftentimes patients will receive antibiotics for that reason. The other reason is that we have learned that in the periods of exacerbation, that antibiotics can, even if there's a viral insult initially, can help with reducing the inflammation that goes along with that and help to prevent worsening of the exacerbation and hopefully staving off hospitalization or worsening overall health characteristics. So oftentimes, even if there's not a directly detectable bacterial infection, sometimes they will be treated with antibiotics because of those properties that we know are present.
Okay, and then you mentioned too some environmental factors. Could you elaborate on that a little bit? What environmental factors could cause an exacerbation?
A great question. So we know that our environment affects lung diseases. That's been known for some time. It's variable per patients, but patients that are prone to having environmental insults like smoke exposures or environmental dusts or pollutants, that kind of thing, can certainly change the dynamics of inflammation in the lungs, which we know changes mucus production and that kind of thing. And when those kind of things begin to change for the worse, that can be when new infections can set up shop and cause an exacerbation or be associated with the prolonged exacerbation. So any of those myriad environmental exposures can cause those. It's much like patients with the more common disease like asthma are known to have environmental triggers like perfumes and that kind of thing are common triggers for those people, or dust. Then in bronchiectasis, environmental exposures can also trigger the lung disease and increase inflammation, making you more prone to infection or infection-like exacerbations.
So with you mentioning asthma, would that be in the category of the host inflammatory response to exacerbation?
Yes, if you think of it as simply as a biological system, asthma is a lung disease in which you have an overly exuberant, usually allergic type inflammation response to triggers, be it infections or environmental exposures. And that's what triggers asthma flares, is something causes that innate sort of excessive immune response to trigger and do more than it needs to. To some extent, bronchiectasis is the same way. We think of it as the more common pathways in bronchiectasis being derived from the neutrophil type cells versus the eosinophilic or allergic type cells that we think of classically with asthma, although we're learning there's a lot of overlap between those two. But in both disease states, the trigger, inflammation, infection, environmental exposures, other things, trigger that already exuberant and perpetual inflammation to get worse. And that's what we think triggers the exacerbation symptoms, at least in part.
Okay, so with each one of these kind of components that contribute to having an exacerbation, we have the bacterial, the viral, host inflammatory response, and then environmental factors. When we look at each one of these, are they treated the same?
They may be. So the treatments may look similar. And I think the way that we narrow down treatments are we check. So I'll just tell you from our experience in our clinical program in Birmingham is that we check if we don't have a clear sense of why someone may be exacerbating, we check for those things. We look for, is there a new type of inflammation? Is there worsening of their white blood cell count? Have their eosinophil counts or other blood cell counts gone up? Have they been triggered into things that can cause exposure-related illnesses like exposure to molds? We check for that, and we check for new infections at the same time. And that way we can sort of tailor how we're approaching the response to exacerbations. And that's an area that I think you'll see explored more in research, is how do we sort of better elucidate what might be causing each exacerbation. We know from prior literature that's been released by several different investigators that viruses, much like in COPD and asthma flare-ups, are a common trigger of that, but we don't know how often the virus is also associated with another potentially treatable exposure and or infection, such as a unique bacteria, a particular type of host immune response, or a particular secondary issue like a bacterial or other cause that can drive that. So I think what we're always searching for is, can we elucidate what's specifically causing it and treat that directly? Otherwise, we're left with more general treatments, general antibiotics, sometimes rarely using steroids, either inhalational steroids or systemic steroids to help calm down general inflammation.
Okay, so after figuring out like what was the root cause of this, seeing if there is an infection, all these other areas. So how does airway clearance fit into this? Is that something that you always recommend for patients?
Great question. So another thing we've learned about airway diseases, including bronchiectasis, is that worsening disease, and especially exacerbating disease, is oftentimes associated with much more mucus production. And with that mucus production is plugging of the airways. Those plugged airways become more inflamed. They become more prone to secondary infections, and they are difficult for them to get better. And if they aren't treated properly, that can cause progressive disease, even in the aftermath of an exacerbation. So airway clearance is a cornerstone of treating exacerbation. So many times clinical providers will say to patients, hey, not only do I need you to take this antibiotic or these steroids or this antibiotic and steroids or this treatment or that treatment, I also want you to increase the frequency of your airway clearance regimen that you're doing at home, because we want to make sure that we're doing everything we can to unpack that excess mucus before it becomes more chronic or before it causes more excess inflammation and winds you up in the hospital or with lower oxygen saturations or more impairment, physical impairment.
So when you say to increase your airway clearance, is that just up to the patient? Like if they're doing it 2 times a day, maybe they would just add another one, or do you try to do it every 4 hours, so 4 times a day?
There is no script or one size fits all. So I think it's really dependent upon knowing the patient and the provider, knowing that between themselves. So a patient that might do airway clearance on a daily basis, if they're having an exacerbation, will oftentimes tell them, hey, you probably should do this twice a day for a while, for a week or two. Or if they're being hospitalized, our protocol in our hospitals that they get airway clearance 3 to 4 times a day with our full regimen of airway clearance, so that we actually make sure we're unpacking that mucus as best we can from the airways and clearing, the infection and inflammation that ensues from that. So I think it's individualized by the patient setting and the individual knowledge of the patient and the provider together as a team working together to think about that. And I think it's also, that tells us that this is why this is a specialized area, because that requires a provider that has an understanding of the complexities of that and how to make the best adjustments for patients in the time of exacerbation.
Yeah. Are there any recent studies that have provided some new insight into maybe the cause of exacerbations?
Great question. There have been a lot of studies looking at, I think a lot of studies looking at what might be driving exacerbations and the propensity for exacerbations. We've learned from several of the international cohorts of patients that we know that frequent exacerbator patients, which might be termed a phenotype of frequent exacerbators, drive.
The definition of frequent, is there a certain amount, what defines frequent?
Right. Great question. So that would be people that have, 2 to 3 or more exacerbations per year. So lots of exacerbations requiring treatment throughout the year. So what we've learned is that's a phenotype of people. And then the question is, what's driving that? And so many studies the last 5 years have begun to look at mechanism behind that. And that's some of what has helped us to define what we should be looking for in terms of clinical outcomes or clinical measures we can make to understand the cause of exacerbation. So we've learned that neutrophilic-derived inflammation, including their elaboration of neutrophil elastase and other we call protease enzymes or serine protease enzymes that are released by the neutrophil, those can drive the inflammation and the development of infections and the propensity for exacerbations. More recently, we have learned that you can have inflammation due to an allergic type inflammation derived from eosinophil cells, which are the typical cells involved, especially with patients that have allergic type asthma. That inflammation can also drive the causes of that. We've also learned that certain infections and the response to infection can cause exacerbations. So, for instance, our group through the U.S. Bronchiectasis Registry has learned that we feel that certain drugs that patients may take can alter the patient's lung and oral microbiome. The microbiome is sort of the makeup of all the different bacteria that make up normal, we call resting flora, or normal resting bacteria that reside in organs that are exposed to the environment, like the mouth, the lungs, the gut. All those have a microbiome in them. And if you disrupt that, we've learned that may cause you to be more prone to getting exacerbations. So as a result, we're learning that there are lots of different things that can trigger exacerbations. And every time we learn a new thing, that tells us a new way we may be able to test for cause and then derive a treatment for that in the severe setting.
So how would you disrupt that microbiome? Is there something that we can do to disrupt it?
Yeah. So one thing that can, well, first of all, the understanding is that the disrupted microbiome could put you more prone to getting exacerbations. And so we've learned that certain drugs, including drugs that may treat acid reflux, can disrupt the microbiome. Frequent antibiotics, if they're not tailored the right way, can disrupt the microbiome. Certain medical conditions, like if you have a condition that alters the gut, like if you have an ulcerative or inflammatory bowel disease, that can change the gut microbiome. And the gut microbiome can communicate to some level with the oral and the lung microbiome and alter those, making you more prone to exacerbations. Furthermore, environmental insults and other inflammation can alter the lung microbiome in its native state, and that can make you more prone to getting shifts in bacteria that cause inflammation and trigger exacerbations, even if a unique bacteria is not recovered from, a standard sputum culture. So this is sort of a next level of thinking about the microbial or microbe environment in the lungs, and one that we're definitely exploring pretty extensively in the research field right now.
Interesting. Yeah, you're hearing a lot of things about the gut microbiome, but I never thought of it as a lung and an oral microbiome too. And so if you're saying protecting those three areas, can you give any recommendations on how one would protect it? Or is there really, you're just exposed to the environments and you can't?
There are actually a lot of ways. One is we're learning what things that patients can do and what things we do as clinical providers may alter that. So it's important for us to understand what medications and when they're given can affect the microbiome. Like, let me give you one example. There have been a lot of studies in the airway diseases field showing that drugs that specifically treat asthma and COPD, like inhaled corticosteroids, which there are a number of those types of medication, if taken long-term at higher doses, can affect the lung microbiome negatively and affect its health. And so we are learning now that we need to, as much as we can, get patients off of excess use of those medications where necessary, relying on them more in the times of exacerbation rather than being a chronic therapy, unless there's strong evidence that they're beneficial for a patient. So whereas 10 years ago, we may have routinely given patients, hey, try a medication that includes an inhaled corticosteroid. Now we're going to try to tell you in clinic, hey, we think we should minimize your dose or get you off that altogether unless there's strong evidence that you need that, because we've learned that deleterious effect. That's just one example. A healthy diet is also very important. So as we discussed earlier, if the gut microbiome is unhealthy, the rest of the microbiome in the body may become unhealthy too. So keeping a good healthy diet that minimizes too much exchange of different types of foods that are deleterious to that are too acidic, that can cause the upper microbiome in the gut to be affected, or that cause you not to have regular function of your bowels. That is very important. So one example of that is keeping a relatively low glycemic diet, because that's known to affect the gut microbiome, which can also affect the airways microbiome as well.
And then how would one protect their oral microbiome?
Great question. So some of it is oral hygiene, right? So you need to clear out things the best way you can. Other way you can do that is we want to make sure that we're minimizing what's coming up. So if you're having issues with acid reflux or even silent aspiration, which is very common in our patient population, we want to make sure we're using a safe medication that can control that, because that's going to affect what's in the upper airway in the mouth, and which connects to the upper airways. And what's in the mouth can become what's in the lungs if not taken care of properly. So we definitely want to make sure that we're keeping good oral hygiene. We're eating foods, also keeping the upper gut, which starts in the mouth, believe it or not, the lower part of the mouth starts the gut, right? We want to keep that healthy with a good diet and whatnot. That will all to help preventing alterations of that microbiome, so that we're protecting it and its interaction with the lungs as a unified whole, especially in the throat.
Interesting. It's nice to hear how everything is kind of connected, and just very interesting stuff.
They are very much, yeah.
So can you discuss any emerging therapies that show some promise for enhancing management of exacerbations?
Yes. So there have definitely been a lot of advances, and there's a lot of studies in the pipeline. So many on the call, many that are listening to this will be aware that there's been recent approvals for drugs, and these are drugs that are targeting an enzyme called DPP1, known as DPP1 inhibitors. DPP1 is an enzyme that stands for dipeptidyl peptidase 1, which is an enzyme involved in the packaging of neutrophil elastase and other of these protease enzymes I mentioned earlier into the neutrophils as they're maturing in the bone marrow, where they're formed, and then so they would then go to the lung from the bone marrow, from the bloodstream, with potentially excess neutrophil elastase, which can then be released and cause damage that we discussed earlier in the discussion. So these new drugs, one of which has been recently approved and others are being tested in this class, actually inhibit that enzyme, thus reducing the amount of active neutrophil elastase that can be released from the neutrophils in the lung and other parts of the body, and thus we think reducing the overall inflammation that's present there, triggered by this excess enzyme. That's one strategy. Another strategy is targeting the mucus itself. We know the mucus issues we talked about earlier can trigger exacerbations and perpetuate exacerbations. So there are a number of therapies that are in the clinical pipeline that target aspects of mucus, making it thinner, making it more easy to expectorate, making it less of it, making it other properties that improve its clearance overall. And so those are another area that's being studied. Finally, there are a number of other we call anti-inflammatory drugs, which are, quote, in the pipeline as well. They're being studied that look at different mechanisms of reducing inflammation, which can trigger exacerbations when one of those viruses or environmental insults or other things cause the exacerbation to it.
If a patient doesn't have access to a bronchiectasis specialist, what would be the best practice you would recommend for clinicians to manage exacerbations for these patients?
It's a great question. This is tailored to each patient. I think the severity of the exacerbations, the patient's overall clinical status, and also the patient's individual background characteristics is going to tell you a lot about how to manage that. So let me paint a picture with two different patients. So one is a patient that twice a year gets a mild exacerbation, usually at seasonal changes, and they have a quote flare exacerbation at times of spring and autumn changes, in which case there's a lot more pollen, especially in that part of the country. We have a lot more pollen happening that time, those times of the year. Many patients will have a quote hay fever flare up, and that may cause them to have a mild exacerbation. Treatment of that is going to be really centered around reducing their exposure, treating allergic inflammation, maybe an antibiotic if they were to get a secondary infection. A patient, let me paint a different picture. Some patients that we encounter, many we encounter in our specialized programs, are patients that have had longstanding bronchiectasis for years. They may have a genetic or other cause of this disease, and they're chronically infected with infections like pseudomonal infections or MRSA infections, and they exacerbate several times a year, sometimes of which they have low oxygen saturations, significant lung function declines, have had to be hospitalized on intravenous antibiotics. And that's going to be a different approach altogether. Those patients, we're going to approach them probably from using anti-inflammatories chronically, inhalational antibiotics to reduce the level of infection, maybe prophylactic type antibiotics in certain instances, and or the use of macrolide antibiotics, which have been used to reduce exacerbations, and or enrolling them in trials for new clinical studies, for new therapeutics, or these new DPP-1 inhibitors as a primary target for those drugs.
How important would you say the role is of having a multidisciplinary care team to effectively manage bronchiectasis?
Yeah, I think it's really important because the disease state is not just I'm coughing, right? There's a lot more to it. There's a psychological component. There's an overall body inflammation that goes along with it, which puts patients more prone to getting complications of the disease, including cardiac complications, GI complications, and other things. There's also a psychosocial component to the disease. It's a demanding disease to take care of on a daily basis. It's fraught with high rates of anxiety and depression amongst sufferers and whatnot. And it's also a disease in which many of the patients are elderly, and so it's going to be fraught with more issues about mobility and other issues which can come along with having a severe respiratory illness. So I think it takes a team to be able to put together how to deal with that illness, especially in the context of maybe a complicated other medical history. Many of our patients have other complicated medical backgrounds that got them to the stage of having bronchiectasis. It may be another severe respiratory illness like COPD or asthma. It may be a malignancy. It may be a prior severe infection. It may be other causes like inflammatory bowel diseases or other genetic diseases and whatnot, in which case there's just a lot to do. And so it requires, managing the overall patient. And that's best accomplished by having lots of people that specialize in different areas and a team approach to try to sort of, put all that together for the patient to achieve their best outcomes.
What self-management strategies would you recommend for your patients living with bronchiectasis to help kind of, just manage their bronchiectasis, manage their symptoms, help them not to get these exacerbations?
Patients ask me all the time, what can I do to make this not happen, right? And we say, there's no one size fits all. The important things are the first thing is you have to know yourself and know your body, right? The second thing is you have to understand what your treatments are and how to best manage those and be able to work those into your life the best you can as you and your provider decide you're going to do those. The third thing is keeping as optimal as can a healthy lifestyle, some level of activity, that promotes overall health. As we talked about earlier, keeping an overall healthy diet, those kind of things can promote you being as strong as you can if one of these exacerbations comes upon you. And that way you're not taken so far down if it's a severe one, right? And so keeping your body as healthy as you can, because that can affect directly the lungs or can affect your healing from a lung issue like an exacerbation. And second of all, being as attuned to your body and to your treatments and understanding and knowledgeable about them as you can, so you can report early and often and in an educated way when you're talking to your provider about what you're needing in times of exacerbation or in times of health.
Thank you so much for being here. Can you just share with us how patients can get involved in clinical research? We've heard all of exacerbations and how research has really moved along that needle with finding out the reasons why patients are having this and coming up with a solution to some of these. So how can a patient really get involved in clinical research?
The first thing is to ask about it. So ask your clinician, your clinical provider. If they're unfamiliar, ask to be referred to a bronchiectasis center, or look up a center and refer yourself so that you can be aware. Most of the bronchiectasis and NTM clinical center network sites are going to be involved with clinical trials, and they're all over the country. And one of the purposes of those is to acquaint patients not only with excellent care for their disease state, but also access to research studies. Second of all, is there's a growing self-referral process that's happening through the Bronchiectasis and Research and NTM Association, which patients can begin to learn about clinical trial access through patient letters and other listservs and whatnot. So I'd encourage you to avail yourself of those through the websites. And I think being an attentive person and following those. And finally, if nothing else, you can always search for bronchiectasis trials and where those are being conducted through clinicaltrials.gov and other websites like that are clearinghouses for access to those trials. And I would encourage anyone that has this disease state to think, at least be aware of what's happening. And then you can, as your disease goes along, you can decide if you're appropriate for referring yourself or asking your provider to refer you to a site to do those trial participations. And believe it or not, there are trials and studies that are happening across the disease spectrum. You don't always have to be an end-stage person with this disease state exacerbating frequently. You could be a patient that has maybe mild exacerbations or has other disease characteristics that we're also studying. So it's never inappropriate to refer yourself for research, and you may learn more about the disease as well, even if you're not eligible for some of the current drug trials.
Thank you so much, Dr. Solomon, for sharing your expertise and practical guidance to help people better navigate, understand, and prevent exacerbations. Thank you for tuning in to the Bronchiectasis and NTM Association podcast. We hope that you found today's episode helpful and inspiring. You can stay connected by joining our online community, following our social media, and visiting our website for more resources. And of course, subscribe to this podcast and join us next time for more insights, stories, and tips to help you live well with bronchiectasis and NTM lung disease. Until then, thanks for listening and be well.